to listen to this talk and ask questions. Welcome again to another Tuesday morning virtual cardiovascular medicine grand rounds. Today, we're very excited to have, one of our own presenting at grand rounds today. It's a pleasure to introduce Dr. Prashanth Vallabhajosyula, who is an associate professor of surgery. He's a surgical director of the Aortic Institute and the assistant program director of the cardiothoracic surgery residency program, and someone that we've all worked with quite closely. Originally from Hyderabad in India, Prashanth came to the United States as a teenager. He seems to be quite a committed Yalee. He obtained his undergraduate degree at Yale College, a master's in molecular biophysics and biochemistry, also at Yale, as well as his MD degree at the Yale School of Medicine. Don't know, he must really like the pizza in New Haven. From Yale, he went on to Johns Hopkins, where he completed his surgical residency with a fellowship at the Oxford Radcliffe Hospital in the UK, and his cardiothoracic surgery fellowship at the University of Pennsylvania, where he spent the first part of his career before being recruited back here to New Haven. Prashanth really is a rare breed. He's a surgeon scientist who really combines his passion for surgery with clinical and translational research work. We're really excited to have him here presenting at Cardiovascular Grand Rounds, and he'll be speaking today on surgical repair techniques for bicuspid aortic valve syndrome. Prashanth, thank you so much for being here.
Good morning, Mary, and good morning, everyone. Thank you so much for the very kind introduction. And you're right, it's all about the pizza in New Haven, and that's what brought me back. With that, I'll segue right into my talk. I have no disclosures whatsoever. I'll just give a brief outline of where we're going and what the goals. I divided this talk into two main parts. One is to kind of give a basic technical layout of how we do primary cusp repair for treating aortic insufficiency in bicuspid aortic valve patients. What are all the things in our armamentarium as surgeons that we can employ, the techniques we can employ to actually get a good result and hopefully provide good long-term outcomes to our patients. And that will be more technically heavy, video heavy session. And I'll also come back with the second part where I just briefly outline some of the outcomes that we've seen with bicuspid aortic valve repair when done by centers and surgeons under experienced hands, and that we can achieve good outcomes. Just a basic introduction to fundamentals of aortic valve repair. We all, as surgeons and a lot of cardiologists also, of course, when they look at aortic insufficiency, we go by this classification. It really helps us understand the disease pathology and technically what is it that we need to be looking at. We look at aortic insufficiency by three types of aortic insufficiency. The types that we primarily deal with where we can employ surgical repair techniques primarily are for type 1, type 2, where either it's a problem with the aortic root that's causing the aortic insufficiency, or it's a dilated annulus that's causing the aortic insufficiency, or there's primary leaflet pathology such as prolapse or tethered or cusp restriction or leaflet tethering. And we employ different techniques for these aspects of aortic insufficiency based on what we see. Now, most common in bicuspid patients, we see that it's never one single type of aortic insufficiency that we see. It's often a combination of type 1B, often 1C, because bicuspid patients tend to have larger aortic annulus, and a combination of type 2. So we typically see type 1, type 2 disease combined when we see bicuspid aortic valve insufficiency. It's important to keep that in mind is what we can do. And you can see there's different repair techniques that we employ in addition to different annular stabilization techniques we employ. Important to know that bicuspid aortic valve anatomy comes in the spectrum, whereas we can see a very simple classic type 0 bicuspid valve, which is a two leaflets that are oriented 180 degrees of the circumference that they take up each of the two leaflets of the aortic annulus. You can see that down here. What we see more common is a type 1 bicuspid aortic valve, which we see in about 80 to 90, more close to 90% of the cases, where you can see that there is a pseudocommissure with a raphe, and the orientation of the leaflets is not symmetric. And you can also see more restrictive physiology where it tends to look more and more, a little bit more like a 3-cusp aortic valve. So it's important to know that when we see bicuspid valve repair, you have to see this in the spectrum and understand what are the different techniques we can employ for each type. The aortic insufficiency, I'll just briefly go through the three main types of presentations. The first kind, in general, we see normal root dimensions, but a large aortic annulus. You can see here, this is a classic bicuspid aortic valve. There's wide open aortic insufficiency, but the aortic root, the sinus of Valsalva are not that enlarged. The ascending aorta is not that enlarged. It's a dilated annulus problem. How do we address this and what are our options? Here you can see an extreme example where you can actually see a normal aortic root. The sinuses are preserved and not dilated. There's aortic insufficiency, but it's actually a sinotubular junction stability problem because the ascending aorta is so enlarged compared to the rest of the root. And that can lead to aortic insufficiency as well. And the most common type that we see when we are looking at aneurysmal disease is root aneurysm with a dilated annulus, which is very common in bicuspid patients. Whereas in tricuspid aortic valve patients, we typically don't see a dilated annulus. Most bicuspid root aneurysms present with a dilated aortic annulus. And that becomes important when we're thinking about providing durable repair. So keeping that in mind, that those three types of presentations are what we see, that's the spectrum. Let me go through a little bit about fundamentals of repair. The basic tenet here is that any purely insufficient bicuspid aortic valve with adequate leaflet surface area can be approached for primary cusp repair. The principles remain the same, and these are pretty algorithmic as we follow when we are in the operating room. The first thing to do is inspection. I'll go through a little bit about that. The second aspect is once you inspect and you commit to the repair is to approach for primary leaflet repair. All the things you need to do with the cusp of the bicuspid leaflet itself. And the goal there is to preserve or to repair towards restoration of normal leaflet motion and to maximize leaflet coaptation. And I'll go through a little bit of the details of this. And the third concept that's very important after your primary leaflet repair work is done is some form of a root and annular stabilization and reduction. That becomes important. So the basic algorithm I'll go through for primary cusp repair. In a type 0 bicuspid valve, all type 0 bicuspid valves with AI can be more straightforwardly approached for primary cusp repair. You can repair the prolapse cusp using plication, triangular resection, resuspension, free margin shortening. I'll give you examples of all this, but all these things can be more straightforwardly approached for type 0. For type 1 bicuspid valve, it's important to look at the morphology of the raphe, the mobility. Often the pseudocommissure is a little bit tethered and calcified. So how much mobility do you have with the pseudocommissure, with the conjoint cusp, and how much mobility do you have, and what does the morphology look like? If the conjoint cusp is not calcified, it's thin, it's just a prolapse segment, then we can approach it straight for primary cusp repair. Now, if it's restricted or calcified, you still don't have to walk away from a repair. Typically, you can resect the raphe, you can resect the calcified segment and see what's left of that leaflet. What's the strength of it? What's the length? What's the mobility? Are there any fenestrations? If all that seems sufficient, then we can still approach for a primary valve repair. But if it's insufficient, then you move towards either avoiding the bicuspid repair or do patch repair. I, as a practice, do not do patch repairs because the long-term durability of the data, the long-term durability is not good. So in today's world, typically in the adult population in their 40s and 50s, we don't go towards patch repair much. But in the congenital pediatric population, it's still something that's done because they're children and you want to give them the best chance possible before mechanical valves. Let's go through the step-by-step approach of this. For inspection, typically it's a 5-minute evaluation that I do, but I'll set a timer or something like that, but you can even take up to 10 minutes if patients have a low comorbid burden. Take your time, carefully evaluate everything. Look at the AI mechanism. Is it a single leaflet problem? Is it 2 leaflet problem? Compared to the TEE findings, you have to really assess what you're seeing on TEE. Does that match what you see in the operating room when you're looking at it? Look at the bicuspid cusps, the quality, the surface area, the mobility. Look at fenestrations, the calcium burden. And also get a good look at the aortic root The coronary arteries, where are they coming off of in relation to the commissures? How does the Valsalva segment look? Is there thinning? How does the subannulus look? Is there calcification there? Is there billowing of the annular plane? All those aspects become important. Here you can see a transected aorta looking at the bicuspid aortic valve, and you can see typically you want to take your time to examine. You want to mobilize, see the mobility of the leaflets. You want to examine, make sure there's no fenestrations. You want to look at the sinus segments. You can see on the video up top to the right, there's a tiny fenestration, but that shouldn't stop you from approaching a repair if that's all you see and the rest of the mobility and all other aspects of the root look good to you. So for leaflet repair, the aspects to look for is leaflet strength. If there's issues with strength like fenestrations, can you close it and get away? Can you oversew the free margin? For leaflet mobility, can you increase mobility of the leaflet by releasing the conjoint cusp raphe? Can you decalcify the annulus or the leaflet and improve mobility? And can you just resect a calcified segment and see what happens? And if you improve mobility with that, then you can move forward. The other major aspect of leaflet repair is to achieve free margin equalization, that the margins of coaptation are equal along both segments of the bicuspid valve. Can you achieve that? And you can achieve that with closure of clefts with primary plication of prolapsed leaflets. Optimizing coaptation zone is the next main thing. Once you've achieved the top three aspects, you want to avoid billowing. You have to make sure that your leaflet repair sits so that the coaptation zone is above the annular plane. If it's below, that's what's called billowing, and you want to avoid that because that affects durability. So you can use techniques to lift up your coaptation zone above the annular plane. Ideally, you want to achieve a coaptation of over 5 millimeters. We'd really try to achieve more closer to 8 to 10 millimeter coaptation. Here's a simple thing where I'm showing how we achieve what we look for free margin equalization. The first thing we do is if we address all the aspects of the primary repair, we make sure that the leaflet lengths across the coaptation zone are equally matched. That is very important to achieve ideal coaptation across the entire plane and to make sure that there's a durability. So that you can see, so the first thing we do these are just 5-O-proline stay sutures that we place to make sure that we achieve that the margins are equal across the entire zone. Here you can see an example where a simple fenestration closure can be done. So this is not a valve that you need to throw in the bucket. This is a valve that can be repaired. So simple fenestrations like this, if the leaflet strength is good around the fenestration, and typically it is because there is scarring that happens, you can repair fenestrations like this and still continue with a repair. You can see here, actually, this patient that we did also has a second leaflet fenestration that we also repaired. Here you can see a raphe release. You can see the conjoint cusp right there being evaluated. And there was some tethering to improve mobility. You can release that calcified portion of the raphe on the conjoint cusp, and you can achieve good coaptation. You can see here that there is a cleft in the conjoint cusp that we're repairing. This is a patient with wide open aortic insufficiency. And clefts like this can be repaired. And once you achieve free margin equalization and there's good mobility, a valve like this can be quite competent and can be preserved. Here's an example of another leaflet repair technique, Gore-Tex free margin shortening. This is a Gore-Tex suture that we use, where you can see that the non-conjoint cusp is the portion that's prolapsed and billowing underneath, causing the coaptation plane to be underneath the annular plane. So to lift up this portion of the valve, this leaflet, we run a running locking Gore-Tex suture line here from commissure to commissure. This allows us to kind of seesaw the leaflet back and forth enough to actually bring the whole leaflet up through this mechanism. You can see we're actually tightening on either side of the Gore-Tex to actually bring up the leaflet right up so we can avoid billowing and improve the coaptation zone above the annular plane. Here's an example of a type 0 bicuspid valve where you can see there's a prolapse segment. You can see that's the portion that's prolapsed. There's some thickening from the prolapse because the prolapse segment gets scarred a little bit right at the zone of coaptation. And typically valves like this, we can actually resect the portion that's prolapsed and primarily reoppose with proline sutures. Once we do that, you can achieve pretty good coaptation. So those are just a brief overview, brief idea, look into all the little techniques that we can use for leaflet repair and for improving free margin equalization and preventing billowing and improving your coaptation zone. The third step we do once we commit to the repair and do the primary cusp repair techniques, employ them, is to actually achieve root stabilization and annular stabilization. This is just like the mitral valve paradigm, where you can do a mitral valve repair surgically, but almost every time that we do a mitral valve repair, we do a ring. We do a ring for annular stabilization. The same concept applies for the aortic root and the aortic annulus. Once you commit to a repair, it is very important to do some form of root stabilization and some form of annular reduction. Ideally, you want to achieve about a 15 to 20% annular reduction. There's many techniques of annular reduction and stabilization, and I'll go through briefly these things. So one is subcommittal annuloplasty, where you actually put sutures underneath the interleaflet triangle underneath the commissures to reduce the annulus. You can actually employ an external aortic ring around the entire annulus. You can do an internal aortic ring. The other more robust but more complex root stabilization and reduction techniques are root reimplantation and root remodeling. Each one has its benefits, pluses and minuses, so we'll go through those briefly. The algorithm for annular stabilization in overall that we kind of go through, bear with me, is the first thing to really look at once you've repaired is to look at the aortic annulus in the bicuspid patient. If the annulus is dilated, if it's greater than or equal to 28 millimeters, and the root is aneurysmal, also, then you commit to a root reimplantation procedure. If the annulus is dilated, but the root is not aneurysmal, it's actually a normal sinus segments, then you can employ other more simple techniques like an external aortic ring or an internal subannular aortic ring techniques. If the annulus is normal and there's an aneurysmal root, you can do a root reimplantation or remodeling. If the annulus is normal and it's a non-aneurysmal root, you could employ an external aortic ring or subcommittal annuloplasty. So this is the algorithm that we go by as we approach what are we going to do with the aortic root and the annulus after we commit to the repair of the leaflets. Here's a video briefly of the subcommittal annuloplasty technique. This is a normal annulus with a normal root. So all you need to do is to achieve some simple reduction in the annulus, because you don't have, it's a pretty stable annulus to begin with. Here you can see the sutures are going underneath into the interleaflet triangle underneath the commissure. And these are pledgeted sutures that we put in to stabilize and distribute the tension safely. And you can see all we'd have to do is after we do the primary leaflet repair is to just reduce the annulus. And you can do it underneath the interleaflet triangle underneath the commissures, and that will give you enough annular reduction that patients can be just fine. And they don't need anything more. This is a much more simple technique that we can employ in those situations. Here's a case presentation that I kind of included for this. I think we have time to go through this. Is a patient with a cleft in the conjoint cusp that you can see here clearly with wide open aortic insufficiency. And they have a dilated aortic annulus, but not a dilated root. So sinus of Valsalva are not enlarged. And the patient has severe wide open AI and is symptomatic. So we do a classic exposure, a median sternotomy, just to orient everybody. That's the aorta up top, that's the aortic cross clamp, that's the aortic cannula. This is your left ventricular vent. So the right atrium is right here. We're looking at, there's the head and there's the feet of the patient. And you can see that when we do the first thing for exposure is once we go on cardiopulmonary bypass and we give cardioplegia, or first thing we do is to completely transect the root above the sinotubular junction to get a complete view of the aortic root. You can see that here. Once we do this, the next thing to do is to examine the valve. You can see what we see intraoperatively matches what we see on the TEE. other than the fact that there's a cleft in the conjoint cusp, the rest of the leaflet mobility is fine. This is a valve that can be saved and preserved and repaired. And you can see there's not that much calcification. So that valve inspection is the important component there where you're committing to the repair. The next thing we do is to size the aortic annulus. So it's a dilated annulus. Clearly, you can see a 29 millimeter sizer goes in relatively easily in this patient. So this is a dilated aortic annulus that we need to address. But you can see the sinus of Valsalva are not that enlarged in this patient. So once we do this, we trim the edges of the conjoint cusp. We trim the raphe that's calcified. You can see we already put stay sutures here to equalize the margins across the coaptation. Once we do this, we actually proceed to go ahead and do a cleft repair. Once we bring the cleft back together with primary sutures, you can see you can have a pretty competent aortic valve. So once we address this component that we've done the leaflet repair, we're happy with our result. The next thing to do is to stabilize the annulus and in fact reduce the annulus in this patient because this is a valve that will billow over time if the annulus is not reduced. This is an example of an external subannular aortic ring. So to do so, we really have to dissect the aortic root circumferentially along, right down to the ventricular annular junction. So you can see that's by the pulmonary artery, by the AP window. That's the aortic root. We are dissecting right along the aortic root. That's the left main coronary artery that is coming out that we're dissecting behind. And you can see that we come along anteriorly towards the right side. Once we do this, we get around the coronary arteries underneath them, because remember, to do an external aortic ring, we actually have to stabilize the ventricular annular junction. So whatever we stabilize and reduce, those sutures have to go underneath the coronaries. Once we do that, and we've dissected down to the ventricular annular junction, then next we put subannular sutures circumferentially. So these sutures go about 2 millimeters underneath the aortic annulus. So there you can see sutures by the aortomitral continuity. These are interrupted sutures that we place, and right by the membranous septum, we avoid placing these sutures because you obviously want to avoid giving the patient a pacemaker. These are sutures underneath going the left side. You can see the left coronary artery is right there being held up. And these are deep sutures that we have to place so that you can really stabilize and reduce that annulus further down. Once we do this circumferentially, we actually size the annulus. We know that it was a 29 millimeter annulus, so we used a 30 millimeter graft. We cut our 3-ring graft and we pass the graft underneath the coronaries. There, that's being passed underneath the left coronary artery. Now it's being passed underneath the right coronary artery there. We reconnect the ring. So in Europe, it's interesting, they actually have a pre-made subannular external ring, but in America, we don't have it. So this is what we use. This is what we came up with when we were trying to adopt this technique for non-aneurysmal aortic roots with the dilated bicuspid annulus, aortic valve annulus. Once we do this, you pass the subannular sutures through the graft and you just tie them down. So here's the final result, and you can achieve good results in carefully selected patients once you can do this. I wanted to give a brief example of the internal subannular aortic ring. This is not something that I use as a technique, but I want to show the audience just so that people are aware of all the different techniques that can be employed that are being used. The internal ring concept is very different. It doesn't require any dissection of the aortic root outside. It's actually a rigid ring called a heart device that actually goes underneath the aortic valve in the subannular position. I don't use this technique, but other people have described and have shown reported good outcomes with it. I'm going to briefly go through the root reimplantation procedure, which is the third root annular reduction procedure with root stabilization procedure. This is for bicuspid aortic valve insufficiency with aortic root aneurysm. So you not only have to address the bicuspid valve, repair it, but you're going to reimplant it because this root needs to be resected. So here you can see this is a bicuspid aortic root that's aneurysmal. Once again, to orient everybody, to the left is the right atrium. The heart's right here. There's the right heart, and we're looking at the aortic root. So this is the non-conjoint cusp, and there's the conjoint cusp of the aortic of the bicuspid valve. Once we do this, we've committed to the valve. You can actually see this is a good functioning aortic valve if you can bring the annulus down. There's excellent leaflet mobility. Even the conjoint cusp just has some raphe tethering, but overall, it's a very functional bicuspid valve. And it's important to take your time to really inspect all this, check for fenestrations. Once we are committed to this and we're committed to the reimplantation procedure and the repair, the next thing we do is to cut out the sinus segments and then cut out the left and right coronary artery buttons. So here you can see that the left coronary artery button has been cut out. So we leave a lip of aortic tissue attached to the annulus, but the rest of the sinus is completely cut off. We size the annulus to get an idea about the kind of graft we want to put in. And another thing that becomes important as we do root reimplantation is you can see that the geometry of the leaflets, the circumference of the aortic valve annulus that's being occupied by the conjoint cusp is different than the non-conjoint cusp. The conjoint cusp occupies about 200 to 210 degrees, and the non-conjoint cusp occupies about 150 degrees. This becomes important for valve-sparing root reimplantations compared to rings because we have to reorient the valve in that same orientation. Here you can see we're doing the deep root dissection. That's us dissecting the right ventricular muscle off the right sinus of Valsalva. This is the non-sinus. And you really come down all the way to the right ventricular muscle. Here, this is posteriorly dissecting the root behind the left coronary. Down below here, you can see the right coronary artery button is already resected off and put to the side. Up top is the left, and this is the non that's still left over a little bit. You can see we'll cut that lip out too. We post our commissures. We're just passively testing the valve to make sure we're still committed to the root reimplantation procedure. It's important to frequently check, reassess, because it's a big operation that takes a long time. So you want to make sure you get it right and do it right perfectly the first time. So once we do that for the valve-sparing root reimplantation, we do the same thing that we talked about for the external ring. We actually will go ahead and place our subannular sutures. There you can see the mitral valve underneath the aortic valve annulus. There's the aortomitral continuity. So those sutures are going into the aortomitral continuity. There's the ventricular septum down there. That's the muscle of the septum. Join to everybody. You can see this valve has a fenestration right there on the conjoint cusp, but that's nothing to worry about. That's a repairable fenestration. So we commit to the root reimplantation. These are subannular sutures that we place circumferentially around. In the interest of time, I'll move this along a little. So this is important here. Once we commit to the subannular sutures, we actually drew it out here to kind of show that we actually orient our graft by the orientation of the valve itself. So I'll go back here just in the interest of time. Also just kind of point out, you can see we marked out the 150 degrees of the non-conjoint cusp and the 210 degrees, 105 and 105 for the conjoint cusp. So we maintain the same geometry as we put this aortic valve apparatus into a new aortic root. So, and the rest of the operation is actually pretty straightforward from this standpoint. Once you're committed to this geometric orientation, we bring our subannular sutures through the graft. You can see here. And then we bring the entire valve apparatus in through the graft itself. So the subannular sutures are tied outside the ventricular annular junction. You can see them being brought down. And that allows us to bring the whole valve apparatus into the new route that we've created here, maintaining the geometry of the aortic bicuspid annulus. That's the left coronary button. And here you see as we're tying down the subannular sutures. So you've reduced the annulus and you've stabilized the graft at the ventricular annular junction. And once you've done that, the rest of the operation is to reimplant the valve apparatus itself. In the interest of time, I'll move this along. So now you can see the aortic valve apparatus with the lip of aorta is sitting inside the new root graft. Then we post our commissures into this graft that allows us to look at the suture line that we need to place to implant the entire valve apparatus inside. Next, we tie down our posts. I'm sorry. Forgive me. And just want to show you briefly what the secondary suture line is. You can see that lip of aorta on the annulus that is left over. We do a running suture line back and forth all the way inside to reimplant the aortic valve into the new route. And then we make our openings in the graft here in the left and right side and reimplant our coronary buttons. And that's the root reimplantation procedure in a nutshell. So having kind of shown surgically, technically, what are all the things we can do and what are all the approaches we use as we look into bicuspid valve repair, let me briefly talk a little bit about the outcomes and what it means. So why repair? Why go through all this? Why not just cut the valve out? Why not just do a Bentall for root aneurysms? Just get it all out. It's a far more simpler thing to do, far less time, less clamp time, less complexity. So why not just go there? Well, so the idea theoretically is that, you know, it's important to maintain the aortic valve apparatus. Maintaining a normal architecture can be beneficial for long term. That's the belief. That's what we think. The potential advantages include that in terms of maintaining the dynamics and the physiology of the aortic valve and the root, I think there's something to say about that, that maintaining those hemodynamic benefits could be more beneficial over rigid prosthesis. Avoiding mechanical valve prosthesis is one of the main reasons why this is appealing to a lot of patients. Most of these bicuspid patients are in their 40s and 50s that I see, some in their 30s. And if we can preserve their aortic valve and offer a good root reimplantation or repair with rings, they can avoid a mechanical valve. And this has become even more appealing to patients nowadays because of the transcatheter valve option, which doesn't exist with mechanical valves. Is that if patients come in their 50s and we can actually repair their valve and give them about 15 years or 20 years, hopefully even longer, or patients even come in their 60s and we can give them that time without having to commit to a mechanical valve, then they are open to the idea of a transcatheter platform in the future. There is data supporting that the endocarditis rates are lower. These are all single institution reports, but there's data supporting that over the long term, the risk is lower. And the risk of thromboembolic complications is lower. And there are several studies that have shown the valve-sparing root reimplantations do better in the long term in terms of, you know, major adverse events, such as thromboembolic complications, bleeding complications, endocarditis complications, and transvalvular gradients. But even then, there is low adoption of bicuspid aortic valve repair techniques. You know, wide application, it becomes difficult because this is something that's primarily been accomplished and done at high volume centers of excellence with experienced surgeons. So there's only a few centers in the country that really do this on a day in, day out basis or week in, week out basis. There's only a few surgeons, if you really count them, who really have worked towards pioneering these techniques and applying them widely. If you look at the STS data, only 14% of patients undergoing root surgery who have aortic insufficiency actually get a valve-sparing root reimplantation procedure. And mind you, that's all patients with root surgery with aortic insufficiency. So that includes 3-cusp patients. If you look at the bicuspid population, it's even less. Because in bicuspid patients, we not only have to reimplant the root, we actually have to do primary repair of the valve itself. And that adds a layer of complexity which most centers have not adopted. So there is still an ongoing debate, and even the experts have a lot of differing opinions about this. Just recently, Dr. Tyrone David, who really pioneered the valve-sparing root reimplantation procedure, or some people call it the David procedure, through many iterations. Basically, there was a debate on what should happen to bicuspid valves. Should they be repaired? And in a nutshell, he basically said the short answer to this is no. Most incompetent, so insufficient bicuspid valves should not be repaired. His impression is they should be taken out. If you look at this in the same debate, Dr. Schaefers, who's from Germany and has done a lot of pioneered these repair techniques, felt the exact almost opposite. So these two pioneers in the field, in the root surgery field, have very differing opinions about how to approach incompetent or insufficient bicuspid aortic valves. His opinion was that we should repair these. Most of these should be approached for repair, and you can achieve good outcomes. So I just want you to know that this is not the end-all be-all. This is a field in flux and rapid and evolving, and hopefully there's more to say. I'll go through some of the centers that have actually done these repairs and what their outcomes look like, some of the big centers, and where do we go from here, just to kind of finish up. So in a series published by the Cleveland Clinic Group, they did 728 bicuspid repairs over a 26-year span. So you can see on average, they're doing about 30 bicuspid repairs a year. Maybe somewhere around there. So 30 to 33 or something like that. It'll be the mean follow-up of 9 years. And you can see that they employed many different techniques, and the techniques have evolved. But for whatever it's worth, freedom from aortic reoperation was about 80% at 10 years. That's quite good if you really think about a field that's over a 26-year experience, that they've achieved pretty good results, satisfactory results. And these techniques have improved over time, and the outcomes have improved over time. But this is one of the largest series out there. There's a series by Dr. Tyrone David, who looked at their valve-sparing root reimplantation outcomes. It was a paper in 2017. This is all valve-sparing root reimplantations that they've done, so tricuspid and bicuspid. But if you see amongst of the 333 patients done in Toronto in their center, only 45 patients were bicuspid patients. So in their approach, as Dr. talked about in his debate, Dr. David talked about, they don't go after bicuspid valves aggressively with regards to repair and reimplantation. But overall, the survival was 72% at 20 years, and freedom from reoperation for the entire group was 96%. But so very good outcomes can be achieved with these techniques. This is from the Stanford group, which is one of the other busy bicuspid valve repair and root reimplantation groups. In their report from 2013, I think now they're up to almost 150 bicuspid valve reimplantations, root reimplantations. In their report, over 14 years, they've seen, greater than moderate aortic regurgitation in 30% of patients. I'm sorry, 30% of their patients had at least moderate or greater aortic insufficiency, and 70% had root aneurysms. They had a high level of Sever's type 0 bicuspid valve, almost 1 in 3, which is very high. And Sever's valves, type 0 valves, are the easiest to repair and reimplant too. But if you see overall, their 6-year freedom from reoperation was 90% at 6 years. This is by Dr. El-Khoury's group, which is probably the busiest and the most premier bicuspid valve repair center group in the world. Their group and Dr. Schaeffer's group are the most aggressive and have the most experience. Dr. Schaeffer's from Germany. And you can see in their series of 161 bicuspid patients, they did a match study looking at 53 patients who had a valve-sparing root reimplantation and 53 patients who had other techniques such as subcommittal annuloplasty. And they found that the valve-sparing root reimplantation offered better freedom from aortic reoperation and regurgitation compared to subcommittal annuloplasty. So this paper really changed the paradigm for us, people who do these repairs and reimplantations, to approach valve-sparing root reimplantation as a more primary technique for bicuspid patients. This is a more recent paper by Dr. El-Khoury's group, and they looked at 440 valve-sparing root reimplantations that they did over an 18-year span, with a median follow-up of 5 years, and 177 of them were bicuspid patients. And you can see their overall survival at 10 years was 80%, and very good freedom from reoperation at 10 years, 89%. But most importantly, what they showed is it didn't matter whether it was a 3-cuspid aortic valve or a bicuspid aortic valve. In good hands, under experienced centers, you can achieve equivalent outcomes with bicuspid or 3-cuspid aortic valves when performing the root reimplantation procedure. This is a paper from our series when I was at University of Pennsylvania. I actually just moved to Yale. I came back about 15 months ago now. I've been here for 15 months, but before, when I was at University of Pennsylvania, this continues to be a passion of mine, but was a passion back when I was there at University of Pennsylvania as well. And we actually looked at all the bicuspid aortic insufficiency patients with root aneurysms, who got root reimplantation with repair and who had a Bentall root replacement, and how do they compare? Can we offer equivalent outcomes for reimplantation as the Bentall root replacement in these patients? And our answer was being selective patients, we can offer equivalent outcomes. You can see here, out of 165 patients with root aneurysms with bicuspid aortic insufficiency, 45 received root reimplantation and 120 underwent root replacement. And we found no difference postoperatively in outcomes. Mortality, stroke, reoperation rates were 0. There was slightly higher pacemaker rates actually in the root replacement group compared to the valve-sparing root reimplantation group, and length of stay was no different. When we looked at over time, this is about at 5 years, because we are relatively new to the field, we started really adopting these techniques in about 2005 to 2007 for bicuspid patients. So our series is relatively more new compared to like the Stanford group or the El-Khoury group and Dr. Schaefer's group. But you can see our freedom from aortic insufficiency, freedom from aortic reoperation, freedom from mortality has remained excellent over time. So in carefully selected groups, you can offer equivalent outcomes with root reimplantation for bicuspid patients as root replacement. I'll finish off with this last portion. There was a study actually by our group that looked at a systematic review of long-term outcomes for bicuspid aortic valve. This is an analysis of 26 studies over a period from 1999 to 2019, so about a 21-year period. And we looked at patients who only had greater than 5-year outcomes reported. Those are the studies that we looked at. We found overall that in select patients in selective centers that report these outcomes, there's overall very low operative mortality. It's less than 2%. There's excellent 5-year freedom from 5-year survival and excellent freedom from reoperation, well over 90%. And while there are some conflicting reports, what overall we found was that the degree of preoperative aortic insufficiency is not associated with successful or unsuccessful repair in the short or long term. So basically, just because there's severe AI, it doesn't mean we cannot do a good repair that's durable. It all depends on all the factors I talked about when we looked at in the operating room and on the transesophageal echo, the leaflet mobility, the strength, the tethering, the calcification. All those play a bigger role than just AI by itself. We did find that commissural orientation was associated with risk for reoperation, meaning the type 1 bicuspid valves are more difficult to reimplant and repair than a type 0 bicuspid valve. You can imagine why, because a straight 180-180 orientation is much easier to deal with geometrically than a type 1 valve, which is more an asymmetric valve. We also found that if there's no aortic regurgitation by intraoperative TEE, you can expect in general to have very good reversible repair. In this study, looking at all the repair techniques that were employed, typically we found that small commissural fenestrations do not influence longevity of repair. So if there's commissural fenestrations, I'll leave them sometimes alone unless they start expanding or extending towards the middle of the leaflet free margin. The valve decalcification is associated with poor repair longevity. That is true. You have to be very careful about valve decalcification, and patch repair certainly is associated with poor durability. I, as practice, do not do patch repairs in patients. If I see that it's not repairable, that's why you have those conversations up front, because you want to give something that's durable if you're going to put patients through a sternotomy. So the annular diameter is a very important consideration. I talked about this earlier. You have to reduce the annulus and stabilize it, especially in bicuspid patients because they have a very dilated annulus. And what we overall found is that bicuspid patients have we can give them good outcomes with reimplantation techniques with annular reduction that's implicit. So we also found that there is lots of data to support annuloplasty. So going back before 10, 15 years ago, this was not being routinely done, but now we all do this. We all do some form of annular reduction and stabilization, similar to the mitral valve repair paradigm. And also it's important to note that there's only a few centers really doing this and reporting their outcomes over the long term. So it really goes to show that we have a long way to go in terms of standardizing and adoption of these techniques and more wide application of these techniques. So what are the valves to avoid? We talked about all the valves that we can repair. Cusp calcification is something to avoid. That's a big no, unless you can really decalcify the raphe or a conjoint cusp and then get improved mobility, in which case you can proceed forward. Restricted cusp motion is something that's a big reason to not do a valve repair. And repairs that you know are going to require patch augmentation or replacement are repairs to really avoid. So in summary, every bicuspid aortic valve patient with pure aortic insufficiency, meaning there's no aortic stenosis, diffuse calcification of the leaflets and tethering, should be considered for primary valve repair with some form of an annular stabilization. Although institution-specific outcomes are promising, repair techniques will need to be more standardized for widespread application and reproducibility. Bicuspid valve repair is associated with very favorable long-term survival with low reoperation risk when done at high volume centers by experienced hands. More prospective observational studies and randomized trials will be required to advance this field further. I'll end this with my own little experience here. Forgive me, it's very brief because I only took over the directorship of the Aortic Institute in June or July of and during that time last year, so in 2020. So since then, since June of 2020, we've now done 24 valve-sparing root reimplantations here at Yale. This was not a technique that was being done here at our institution before. Routinely. 7 of those patients had bicuspid aortic valve of the 24. We've now also done 16 cases of isolated aortic valve repair without a root reimplantation, and 6 of those cases were bicuspid patients. In the short term so far, and I can only talk about short term, of course, in our hands so far, our mortality, aortic reoperation rate, stroke rate, pacemaker rate have all remained at 0. Our freedom from greater than mild aortic insufficiency has been 100%. So we can do this right. We can do this in carefully selected patients and achieve good outcomes. Obviously, only time will tell the durability, proofs in the pudding. So with careful adoption of these techniques that I kind of briefly outlined, our institution has a potential to develop into a leading center for valve repair as well in the aortic space. Thank you very much. Appreciate it. I'm going to stop sharing the screen. Is that what I should do, or should I stay on?
That's fine, Prashanth. You can stop sharing your screen, and I'll just open the floor for any questions.
Thank you.
Hey, Prashanth, it's John. How are you?
Hi, John.
So it's an interesting field, and I think there certainly is a lot of debate about repair of it. As you know, some centers have gone away from it, and and some have adopted it. And the it takes expert surgical hands is always a tough thing to debate. What I would challenge you on is that there needs to every study you showed there is a retrospective analysis. And there have been thousands and thousands of bicuspid aortic valve repairs, and the data is all over the board. You know, some define long-term as a year, some define significant AR as greater than 2+, meaning like 3+ AR, whereas the surgeons would then argue that if you have mild AR after a TAVR, it's significant. And so it's all over the place. Why not do a randomized study? Why not do a randomized study, take the 10 best places and say, we'll do a randomized study of surgical aortic valve replacement to surgical aortic valve repair?
I think you hit the nail on its head. I think that is going to be what the surgical space needs to do. There's no doubt about it. The only way to truly address this is, even in experienced hands, can you truly say that these valve repair techniques are just as great as cutting it out, throwing in the bucket and replacing it? Can we compete with a tissue valve or a tissue Bentall or a biologic valve Bentall root replacement in this space? Well, there's good data that is all retrospective, as you talked about. From a retrospective standpoint, yes, there's good data to support long-term that this is better, but only a randomized trial can really answer your question. And you're right. Why not do it? I think that patients come, more and more patients come with certain opinions in mind. Patients who come for valve repair want the valve repaired. They don't want the option of getting a tissue valve if they don't need to, or a mechanical valve if they don't need to. So the trick here is going to be truly convincing patients and the referrals that this is a valve that looks totally repairable to me, but I'm going to cut it out, throw it in the bucket, and give a mechanical or tissue valve. That is not an easy, straightforward conversation and discussion to have. But I do agree with you that that is an important discussion and an important study to do if we're truly, objectively, with equipoise to address this question.
I hear you. Yeah. No, go ahead, Eric.
I was going to say, you know, we're fortunate at Yale because we have expertise here, you know, with Prashanth now and John in the bicuspid space substantially. So I guess the question I had to Prashanth, and John, feel free to check in later as well, is there a difference with regards to the ability to implant in today's world a TAVR in a repaired bicuspid valve versus a replaced tissue valve? And so in other words, if we're looking at the patients at the age of 40 to 50, and we're looking at a 30-year time window where there's a good chance we might need to do a second procedure, which one, based on today's knowledge, would be more docile, I guess, for a TAVR second procedure? And
yeah, I mean,
maybe.
So we've had a handful of patients referred to us after, and this is before Prashanth getting here, fairly shortly after, within 5 years of a repair for aortic insufficiency. And if the failure mode for that valve is recurrent insufficiency, we don't have a transcatheter valve to go in there. If the failure mode is aortic stenosis, which is fairly rare to get sort of, quick aortic stenosis after a repair for insufficiency, then we can. It's dramatically easier to put a valve inside a surgical tissue valve than inside a surgically repaired valve.
John's right about that. And a lot of these repairs will fail by aortic insufficiency, recurrent AI, as John mentioned. But in the root reimplantation space, which a lot of bicuspids actually do end up with root reimplantations when we repair than root just primary repair, it's because they often come with a dilated annulus. There is space to do a TAVR valve, because there you have already fixed the ventricular annular junction. So there's a fix. It's like doing a homograft TAVR. You see, when we replace a patient with a homograft, or porcine xenograft, or a homograft where there is a root replacement, you have an annulus that is now not as mobile. It is fixed. In those situations, we've had successful outcomes with the TAVR. But if you do a primary valve repair and don't do anything to the annulus, then John's absolutely right. You are stuck with the reoperation. And that is why I think it becomes very important that if you're going to commit to this, that you have to be confident about your repair. And that's the tricky portion.
Thanks, Prashanth. Jeremy Naderman, you had a question. All right. Don't know if he's still here. I'll ask Al Sanusis to unmute and ask your question.
I just had a question with regard to how you use echo, whether it's transesophageal or CT in the evaluation and the sort of surgical planning and follow-up of these procedures.
So you bring up a great point, sir. It is so that the TEE is so critical in terms of making the determination. And so when I have a conversation with patients about repair, if they don't have a TEE and the TTE is sufficient, we talk about percentages that I could potentially repair this. And you have the conversation up front where if I tell them, what would you want if I can't repair this? And I just based on experience, I can give them a good percentage number and they make the decision. And once they do intraoperatively before we make incision, we sit down with the cardiac anesthesiologist and go through the details of the TEE. I, for one, actually have a sheet of paper that looks at about 14 parameters in the aortic root complex, everything from intracommissural distances to leaflet height to annular dimensions, sinus dimensions. All these things I record from in the pre-incision TEE. And we go through all these things about AI, how's the jet, eccentricity, pressure halftime, all these things. And then we do the same assessment after the operation too. The reason why I do it is, and so when I came to Yale, I started this, is it's so important to follow all these elements of the aortic root complex to better understand where you're going. As John pointed out, yes, we can offer great outcomes post-operatively, but it means absolutely nothing is if at 5 years these things are failing. That is not a success. That is a failure of the repair operation. So, I think to understand that better, this is so key that the TEE and the intraoperative measurements are taken, observed, learned, and it's a learning curve. Cardiac anesthesiologists were not routinely used to doing this before I came. Valves, root reimplantations were not being routinely done here. So we learn together, we grow together, and you record all these things. As I showed in one of the videos, you can see that bicuspid valve with the cleft in the conjoint cusp, where the AI jet is so evident on the echo. So the echo is so key for us. And I think that from our standpoint, when I was at Penn, we actually had cardiology partners from the echocardiography space who were interested and worked with us. And I think that, if something hopefully can come out of this grand rounds, hopefully it is that ability to do so with cardiology partners here who are interested in this space, who would like to work with us in this space and to grow together in this space. Because I think the input is so key to making these determinations.
Thank you so much. We'll take one more question. We're right at the top of the hour. Dr. Bender.
Sorry, I don't hear. Dr. Bender, I think you are muted.
How about now? That was a terrific talk, and congratulations on all your work, which has been wonderful. There's this ongoing pathobiological mystery, to use a funny term, about bicuspid valves. You know better than I do. They thicken. There's excessive matrix deposition, calcification. I don't know if you select against those because calcification is a relative contraindication for the repair, but I wonder if there's anything that's been learned by following these repaired valves over 15 years to see whether those repaired valves remodel at the same rate as pre-repaired valves, because the question about hemodynamic contributions to the pathologic progression has been there for many years.
I think the best way that I can answer your question, and it's a great question, is that the series that looked, and mind you, these are retrospective, and we have to take that into consideration as we look at this, is that, you know, if you look at the series where we did one at Penn, the El Khoury group in Belgium's done this, the Stanford group's done this, these few centers have done this. If you look at the 3 cusp aortic valves, which one can say maybe are the normal valves, quote unquote, and you do a root reimplantation in those cases, and you look at the bicuspid aortic valves and you do the root reimplantation. In those centers which report these outcomes, there's no difference. There's been no difference. So I think that the thought process is that if you have a patient who has a aortic insufficiency, a bicuspid patient with aortic insufficiency, a 45-year-old, but the leaflet integrity is overall good, there's no major calcification, there's no tethering. If that valve has done pretty well for 45 years, I think there's a good chance if you overall can repair it without causing much distortion and giving it a new root with a stabilized, reduced annulus, you can get good outcomes. And I think so far, although retrospective, that's what the data is suggesting. But I think you're right that, you know, we need to dig deeper into this. There's almost, you know, you look at the literature, there's no autopsy series on these reimplantation patients with bicuspid. I would love to see that. I would love to see, well, what's actually happening? What's the histology look like? What is the, we just haven't gotten there because the centers doing those are just so few.
Good. Thank you.
Thank you.
Prashanth, thank you again so much for
Thank
that
you.
wonderful talk. It was absolutely excellent having you on, and hope to continue to work with you in the future. Thanks everyone, and we'll see you again next week, Tuesday. Bye.
Thank you, everyone. I'm so grateful for your time. Thank you.